Good evening, everyone. Welcome to MedSynapse and Doctors AI present Med AI Web Hour. I'm Dr. Ishwarya Sharma, the moderator for today's Web Hour. This is something that we started last year in January, that we meet every second Thursday of the month, and we discuss AI and how it's been used in medicine by stalwarts of medicine who are using it in the very effective manner and doing it in a pioneer way. So today there is another wonderful session, which will be a session, and we will continue it into a panel discussion. So firstly, I thank you everyone, Dr. Angeline, Dr. Biju sir, Dr. Parthasarthi sir, for your time, and I welcome you to this MedAI Web Hour. I would like for you to know Dr. Angeline Raja ma'am. If the team could present her introduction. Yeah, thank you so much. So she's a member of American College of Artificial Intelligence. She's the Dean's Council member of Indian College of Artificial Intelligence in Medicine, and developer and evaluator of large language medical model, massive open online validation and evaluation program, Light Switzerland. She's an AI faculty of Indian Academy of Pediatrics, AI faculty of Indian Society of Critical Care Medicine, of National Institute of Technology. She is the advisory board AI for surgeons and associate editor of International Journal of Artificial Intelligence in Medicine, research associate at BrainX USA, and subject matter expert of DocStribe AI. I welcome you, ma'am. You are a very integral part of Doctors AI community at large, and I would really like you to chair the session today and introduce another chair and our guest. Thank you.
Thank you so much, Aishwarya. Am I audible?
Yes,
yes, madam. Yes.
Yeah. So good evening, everyone, and welcome to the update hour. And thank you, Dr. Biju and Dr. Partha, 1,000 times for being kind enough to accept our invitation and bring your expertise here. A brief intro. Artificial intelligence is rapidly transforming many areas of medicine, as you know, from interpreting clinical images to predicting patient outcomes. It is helping clinicians make better and more timely decisions. So one of the most exciting frontiers for AI is in surgery, where technology is beginning to enhance how we plan, perform, and thereby evaluate surgical care. So to help us explore this fascinating intersection of surgery and technology, it is my great pleasure to introduce our speaker today, Dr. Biju, and I'll give you a brief. Yeah, Dr. Biju is the professor and head of surgical gastroenterology, JIPMER. He's done his MBBS from Calicut and then his MS and his MCH for surgical gastroenterology from the Sanjay Gandhi Institute, Lucknow. He is the head liver transplant unit and former associate dean at JIPMER. He's done many national roles as secretary of the IHBBA Indian chapter, the vice president, and the executive committee of the ASI. He's editor-in-chief, Journal of Nutrition Research. He's done n number of indexed publications, chapter textbooks, and invited lectures. He's a mentor to PhD students, postdoctoral fellows, and also an examiner for the National Board of Examinations and multiple universities. His expert roles include the National Health Authority committees and SOTO, Puducherry. He is a special officer for the upcoming Institute of Organ Transplantation, Kerala. Thank you very much, Dr. Biju, for being with us today and bringing your expertise. Now, coming to the introduction to our chair, that is Dr. Parthasarthi Govindraju. He's a clinical director, Department of Surgical Gastroenterology and Robotic Surgery, KIMS Hospitals, Hyderabad. He's done his MBBS from JIPMER and MCH from Sanjay Gandhi. He has a fellowship in liver transplantation from South Korea. His clinical expertise includes minimal access and robotic surgeries for GI cancers and complex abdominal wall reconstruction. He is the faculty for the NBE, and his academic contributions include 50 publications to index journals and textbook chapters. His active interest is in surgical innovation, robotic surgery, and technology integration in surgical practice. He is engaged in ongoing very many clinical and surgical research projects and innovations. Again, Dr. Partha, thank you all so much for being here today with us. So, Dr. Biju, probably you can start.
Yes, yes. Thank you. Thank you, madam, for the kind introduction. So we'll be talking about artificial intelligence, minimal access surgery, and robotics. So artificial intelligence, when all of us got some interest 10 years back, we were all frowned upon probably what these people are doing in medicine. Okay. So we were not actually dare enough to give a speech and in podiums and conferences. But as Dr. Anjali knows that at 10 years, probably we are actually a few speakers in artificial intelligence in medicine. That is the reality because the game has changed a lot. So in fundamental, it is a perceiving, synthesizing, inferring, and acting by machines. Okay. So this is going to rule the world as well as medicine. So we need to understand two concepts, machine learning and deep learning. Both are no new intelligence, but it's trying to develop its own artificial intelligence based upon a perceived data. So what really happens is you need a lot of inputs. As the number of inputs increases, the accuracy, sensitivity, specificity increases. Then from this data, there is a process called feature extraction happens. That feature extraction goes to a neuron, multiple neuronal networks, and it produces its own language and modeling, and it positively try to predict. So when this concept comes to surgery, we have to understand how this is going to help us. So what is the problem in surgery now we are facing? Okay, so surgery is done with hand, and we are used with the movements of the hands and movements of the fingers as well. When we try to replicate this to the instrument tip, we always failed very miserably because the finger has more than 30 degree of movements, degree of freedom of movements, but here we are getting hardly 5 to 6. Okay, so we suffer from less tip length, less freedom of movement, attenuated hand to instrument tip. All this we suffer a lot. So we come with a smart instrument. So smart instruments, what we do is we try to manipulate the tip, modify its shape, surface, and we try to put robotics into that. But if you see it correctly, even the robotic instrument tips works with a very crude pulleys. Okay, the tip is at working at pulleys, and that is how we do. So we try to create a multiple degree of freedom, but at the end of the day, what is happening is basically you are still dependent on, you can see the last picture there, a lot of wires and pulleys. You have artificial intelligence at the base, but there is no artificial intelligence at the tip. It's not moving at the tip. So this is how it happens. Okay. Now, when you try to convert this AI introduced to instrument, which is one of the very major lacunae, we need something called a smart instrument. This instrument has to move not only at the tip, instrument has to move at the body as well. So the 3D printed technology is very common now. The 3D printed steerable instruments are going to come to the market very soon. So what we are going to see is you have an instrument will work like an endoscope without much difficulty. So it will act like a hand. You will have more comfortable to manipulate this. So both the major body part as well as tips are going to move in a long run. So now, when you put a much more next level of AI in the instrument tip, what happens is, now as we know, surgery, we are trying to create the reality in the environment. The surgical environment, you create a reality, you magnify it as less size it, and we perform surgery. Now, this is one of the areas where we are going to get a major hit. For example, you have a scissors, what you are inserting is a scissors, but probably what you are going to see in the operative field is some other animated instrument. So the animated view of the instruments are going to come in the market very soon because of the AI, and we should be very used with the animated view of the operative field, especially in the instrument area. And the another area where innovation is going to happen is the instrument won't give you the exact feeling of the tissue. What it gives a very crude feeling, and we perceive it at the tip. But if you put AI in the instrument assembly altogether, let us say the instrument is touching the liver, the AI algorithm program in such a way that it will give a feedback in your mindset that you are touching the liver, or you are touching the bone, you are touching the intestine. So this haptic feeling, the real haptic, okay, it is not the haptic what we talk in Da Vinci or robotics. The real haptic is going to come in the AI, and it is going to transform. So we will have the similar feeling what we feel with the hand in AI very soon. Now, one of the very few examples where we can quote what last 10 years AI is actually working is the energy source. So what it really does is, if it touches tissue, let us say it is touching a very soft tissue, it is perceiving the density and adjusting the current accordingly and deliver it. You need not adjust the current automatically with your hand or other methods. So the moment you touch a hard tissue, it needs more current. It feels the tissue, it perceives and give back the current in real sense. So this energy devices are already there, but this is one area it is going to transform in a very big way. And the fifth front, which is going to have a very major impact on our healthcare or vision front, is we are going to have a completely 3D and animated view in the operative field. Let us imagine a scenario where you are operating the abdomen, and the organs are actually coming out and show you the actual 3D view. Now the 3D view is artificially engineered, a very minimal 3D view, but at the same time, imagine that the organs are coming out from the operative field. And also, second most important point is, let us say you are doing a cholecystectomy, you want the calyx only to be brighter, only to be enlarged. So relative proportion of the operative field and the organs are going to come. So you can have a small gallbladder with a large liver with a small gallbladder. All this depends upon your camera position. This vision is going to come in the operative field, and this will drastically change your mindset, environment, and the operative assessment as well. So this will be especially helpful in microscopy surgeries, and we are not even sure whether now microscopes is going to be there in near long-term future. Okay. So this smart interactive AI-based vision is going to come. So now we work on contrast. You need a CT, so you need a contrast, but this, because tissues have different physical properties, it exhibits different physical properties. Probably this contrast area is going to have a major hit in the market. You can have a gallbladder in different colors, you can have liver in different colors, because of its merely physical difference in properties. So this is how it going to work. This is doing a cholecystectomy with the bile duct is in a, so there is no contrast here. Please understand, this is completely a tissue property, physics only working, AI only working. You have gallbladder, bile duct, calyx, artery, everything is a different color altogether. This is going to help the surgeon. And imagine that this is coming in different sizes. You focus the calyx, and calyx become bigger compared to the other areas. So the fluorescent dye area is going to have a major hit in near future after 5 to 7 years. So already the companies like Olympus come out with the yellow enhancement or white enhancement. The fat is becoming detected more and more in AI, but the actual tissues we can detect it more. So we are going to use the real tissue intensity and density rather than contrast, which is going to come in near future. So this is what the dye-less enhancement, white light and yellow enhancement. Now the if you stretch it too far now, what is going to happen is now we are working on normal cameras. You detect the vision from normally. Now imagine a scenario where your AI platform it starts detecting the molecular changes or molecular architecture of the tissue you are visualizing. So here is a situation where cytokeratin 7 in the bile duct is getting detected in AI platform, and it actually gives you a cholangiogram. So where are we going to add? You see very beautiful finer structures are there. What we are going to do with the CT and MR if the things are advancing at such a faster pace. So this is going to be a very disruptive, revolutionary and major game changer in the future. So this is how it looks like. You can see the animal liver, how it works. Even small arteries you can have. So from the structure, let us say you have an artery, which is a tube-like structure it detects. It is going to the wall of the artery. It is going to the cell of the artery. It is going to detect the nature of the cells in the artery. It recreates the image using AI and giving a arteriogram, cholangiogram, and venogram. This is going to be a very disruptive technology. So then integrated imaging systems are going to come. Image-based tumor pathology and biology is going to come. Advanced solution for automatic tasks also going to come. So now how the imaging front it helps. So we have conventional CT. We are used with the contrast CT, but the fact of the matter is plain CT also give a lot of intensity information. The problem is we are although we are getting a huge amount of data because of the weakness of the processing platform, we are not able to give the viewers the exact color image or the difference image. This is going to change in a very big way. So as I mentioned, the feature extractions expanding in exponential way, the segmentation structures are going to expand in an exponential way. So all the non-enhanced CT are going to be much useful in future. Please look at the non-enhanced CT, its resolution. This is going to be another game changer. You can create arterial and venous images from there. So again, it's a generative AI. What we have used in our department is a GAN network. We trained a model and tried to create images, something like that. So you can also see how the last part of the images, how the just look at the layers it is getting developed. These are developed from the plain CT as well. So if you use contrast CT, it will be much more interactive, much more information. You can see the difference between this right side image is created just from a plain CT. See just look at the layers of the skin only. Okay, so how many layers are appearing and just compare with the plain CT. This is the beauty of the depending on only on physical property of the tumor tissues and nothing based upon the contrast. So there is no contrast here. Still you can see fat structures inside the liver. So it's a very crude unprocessed image. The crude unprocessed looks like this. You can imagine how a much more processed image can come from a plain CT. So you can have metastatic features, normal features, all the hemangioma, everything you can visualize. So this is possible because of the excellent segmentation and its architecture in the AI front. Engineers works a lot. A 3D can be made, and you can also imagine that our 3D printed liver available for you on the previous day for surgery. You do the surgery on the 3D printed liver and do the same surgery next day. So this is going to be very exponentially effective in the surgery in the future. So this is our own created surgery planning images. You can see that how the number of tumors are visualized and how the structures are also visualized. Currently, you can imagine that these are very costly platform. Even one best platform costs almost around 50 lakhs, although it is a software and companies charge a lot. So this is going to be a very another game changer. So surgery planning for liver tumor, there can be fatty liver assessment, tumor assessment, and also the vascular front assessment also as well. Now, the manual interface which we are going to sit with these images processing is going to disappear very soon. So fully automated visualize. So that means you are acquiring the data, processing platform will give you in whatever we want. Although we see beautiful pictures now, please do remember that it's a good amount of manual interface is there, which is going to disappear very soon. And this is one of the fully automated visualization platform we have made. So it is quite possible. So reducing the manual interface and without any polishing, it is going to give you a very crude data. And please do understand that any sort of color applying to this, any sort of dimension applies to this, it's a very, very simple exercise in AI and rather than creation of the architecture. So then another important area which we have to encounter in future is, you imagine why we are getting a PET scan. PET scan we are getting, why we are getting a contrast CT. We are getting this because we also want to know whether the tumor is really aggressive. What is the metabolic activity of this tumor? But we have to remember that there is physical property of the tumor. Each area of the tumor works differently, its intensities are different. But as I said earlier, we are unable to capture into a visual or other formats. So here, what we have attempted is the AI platform gives you a vascularity, it assesses the tumor and its cellular vascularity, and it recreates the images. So the same size images, same size tumor can be predominantly highly aggressive, moderately aggressive, or less aggressive, senile, young and adult areas, we say jokingly, and this can have major implication. For example, you can actually calculate the aggressiveness. You can give, okay, this tumor has 50,000 aggressiveness, the other tumor is a different aggressiveness, and accordingly your therapy can change. So this is also another transformation. And tumor vascularity, aggressiveness, your aggressiveness can be really measured in terms of volume. You can see how the same size tumor happens. So the first image, highly aggressive tumor is 36%, whereas in the second image, it is hardly 1% of the entire liver. The size is same. So this is going to be a disruptive and transformative technology. And as I mentioned, creating 3D models, AI-based 3D models, and also interactive need-based 3D models. You want the liver to be flat, you want the tumor to be out of the liver. All these are going to happen very soon. This is one of the 3D models we have created in our own department. And real-time grayscale, or so you have CT ultrasound acquired earlier. You are going to get these images in real time in front of your camera. You put the laparoscopic camera, these images are going to integrate in real time in future. With a press button, you can change the operative field to grayscale or color image based upon CT and ultrasound in near future. So I already mentioned about a steerable instrument, but this steerable instrument has one more advantage. Why I mentioned here, because these steerable instruments carry its tip another imaging platform in the form of ultrasound, so you can reach any area and you can image it very well. So as I explained earlier, situational enhancement AI can help. You want a particular area to be dull, you want a particular area to be better. The situational enhancement and artificially engineered surreal, non-real images are going to come in your operative field in a big way in future. Another important advantage, how it is going to disrupt the pathology department in a big way. You got the tumor removed now. You imagine you have a capturing device like an intraoperative ultrasound. It has a program to detect highly aggressive or moderately aggressive tumor. You apply the probe over the removed specimen, and it also give you artificially engineered virtual histological images in real time in future. Now, all this can be incorporated tumor ablation, robotics system, laparoscopic system, instrument systems, and all. Now, 5 minutes I will talk about how it is going to influence the robotic thing. It's going to instrument the dexterity of the tip movement from fully we are going to change it. It gives a very good 3D, 4D, 5D, or 4K or beyond vision. and coordinated movements at a fixed narrow spaces. This is the robotic platform we use. Although we call it robotic, it's a fully human control. Then not much robotics is going to be involved in this machine. But in the future, what we are going to see is the real AI is going to come and interface the functions of this instrument in terms of visual feedback, and more algorithms are going to come. So the camera tip or the small chip-based cameras installed at the instrument tip is going to be the capturing agencies of this, and it gives you real-time large volume data. And let us say you have a scissors and another grasper in the field. There's a camera at the scissor, there's a camera at the grasper also. These cameras are going to interact each other. It is going to fix the distance without any damage. This is happening in real time in a very crude way, but this is going to happen in a very smart way in future. So this hand-eye coordination is going to improve. Hand-eye coordination is also going to be semi-automatic, and it is on the pathway to become fully automatic. So man-machine interface dominates the action. So you put your hand in the robotic console, it is going to be really transformative. In the future, manual overrides are going to come down in a very big way. So one of the problems we face with the robotic technology is the platform away from the patient. This gives a inherent fear in the surgeon as well as the patient and the team. So this is also going to come down in a big way, because the size of the consoles are going to come down. The robotics are going to be incorporated in the instrument tip and also the handles of the instruments. The importance of surgeon console is going to come down again and again. So surgeon will again start moving near the patient. And you see the innovations happens in the orthopedics and other artificial limb. The degree of freedom happens. So a person who has artificial limb or artificial hand is going to be much stronger than a normal human being. Let us say a person is wearing an artificial hand. He can crush an iron bar with an hand. He can't do it. Okay. He can go to small holes. He can extract the difficult area. So imagine that this hand technology is going to incorporate into the robotic arms and the laparoscopic tape arm, how it is going to transform the surgical field altogether. So we are trying to create the hand movement there, but the technology is helping us to create 100 times or 1,000 times more strength, dexterity, fineness, and cuteness of our hand movement in real time. So this is also going to be a very, very disruptive technology in the future. And this also can happen in AI in endoscopy. So imagine that the self-navigated endoscopy is going through your esophagus. It reaches there, it visualizes a tumor, it gives you AI engineered images of the tumor, it gives you vascular the tumor, it also gives you a real-time pathology. So these AI platforms are going to give all-in-one solution because of its navigation advantages as well as deep learning advantage. So, but cost is a factor. It is going to take time, but with any other technology, it is going to be a really, really transformative technology. So it also gives advantage education simulation platform. It is already happening. And the last area which I wanted to tell you is it is going to create a immersive reality environment. For example, a student, why is going to operation theater to watch the surgery? So that's what our assumption is. Imagine a scenario where there are multiple cameras across the operative field. He's actually seeing the operative environment, the surgeon, but with a very small wearable device. So sitting in your own desk, you are a consultant, you are in your room, you can actually see what your assistant surgeon is doing, what your junior resident or senior resident are doing. You can take control of the situation. You can actually, with a voice over protocol, you can control the instruments in the dangerous step. You yourself with a simple voice command can stop the scissor cut or movement of the camera as well. So So imagine a scenario that you are controlling the surgery in the midway. For example, you are taking a rounds and in the middle of the rounds, eighth patient you are reached. That time your resident is calling us, or I am not able to proceed. There's a problem in the calots. Can you come? So from that eighth patient, you tell, okay, I'm stopping the round. 2 minutes, I will help him to dissect. You can do it in real time. This is a real possibility. It is going to happen, and we think that these are all in going to happen in 25 to 30 years. No, it is going to happen in the within a decade as well. So this immersed environment, immersed reality is going to come in a big way. And that is all I have to tell in brief. And thank you very much for the kind attention. Yeah.
Thank you so much, sir. Thank you for such a deep and immersive talk. Over to you, Dr. Angeline, ma'am, and Dr. Parthasati, sir.
Thank you, Aishwarya. Thank you, Dr. Biju. I was spellbound, especially AI coming in and taking robotics closer to the patient and the doctor was unthinkable. And sort of, is AI going to bring back the human aspect of a doctor patient relationship where all the time we were decrying, saying AI has brought a gap between the doctor and the patient? Here you have brought in a very important point. I am really very thankful for you having brought it up. And all the future possibilities that you told are just awesome. Again, thank you, Dr. Biju. I leave the floor to Dr. Partha, another robotic surgeon who will be able to give us better insights.
Thank you, Angeline ma'am. It was an absolute pleasure listening to Biju sir give an exciting and very passionate talk on this AI. Definitely the work he's doing in this is showing in the presentation. Dr. Biju is my teacher, and it's always a pleasure to listen to him talk. We are still looking at what the future is holding for us through the presentation. Looks like we thought by doing robotic, we are at the cutting edge of surgical technology, but then we feel that we are actually in the stone age of that. So we are just using a more efficient machine and working as humans, and AI is going to transform that thing completely. So one question I would want to ask Dr. Biju, because he seems to be in the thick of all of this. Sir, most of the work I see is happening on the therapeutic. I'll confine it to the surgical AI. So most of it is happening in the field of therapy, like in enhancing surgical decisions and the conduct of surgery. What is happening on the diagnostic side of surgical branches? I know there's a lot of things happening in radio diagnosis and endoscopy. In surgical diagnostics, is there enough research happening in helping us to decide, diagnose, and personalized treatment for surgical problems? Like we have personalized treatment in oncology. Can we also, is there any AI work happening on these fronts?
Yes, very much. See, the concept of surgical science is we try to make a uniform protocols everywhere. So we depend on crude parameters like size, number, and the feature which is highly palpable or readable. Very, very, very crude way. So how the AI is going to transform this technologies? AI started reading the deep physical properties of any structure. For example, you take a fatty liver in one person and fatty liver in another person. Okay. The capturing platform like CT and MR is actually capturing the simple 10 standard physical differences between these two livers. But it is not giving us the output. That is the problem. This is going to be changing in future. So what is going to happen is you have a, let us say you have a tumor in the liver. The density of the tumor, it will give you the actual mathematical value. Let us say 1,20,038 is the mathematical value of 1 centimeter of this tumor. Another patient, it is just 38,000. So doctor, please look into this. These tumors are different. You have a similar biology. You have a similar FT. But your pathology is similar, but please look into this. So this is going to be another sort of tumor marker in future. So what the another important application is, see, the tumors and all that enhances at the edges. It grows at the edge. So which area is going to grow in next 2 months? It is going to predict. Let us give a tumor to a AI specialist, map the tumor and ask him to tell, see, I want to know whether this tumor, which area is going to grow, and this patient number 1, what is the expected size in next 3 months? Patient number 2, what is the expected? You see how the surveillance protocols are going to change drastically. That is why I'm insisting that it is going to be a game changer. So, because we are now going to the real science, real physics, chemistry and biology of the tumor. That is where the AI is changing. Yeah. Thank you.
Coming to another non-technical point regarding the social and the ethical implications, any new technology which becomes effective definitely puts certain centers above the rest in terms of delivering healthcare. With the rapid advancement of AI and with this expensive type of technology coming in, we can expect a very wide rift between a certain group of centers and a large majority of centers which cannot afford or have them. So do you think AI will work more to integrate healthcare or to divide healthcare in the next few decades?
So it is going to integrate, because the although we talk about big about AI, the number of innovators and innovation centers across the globe is too much. So this is going to be highly competitive, and the rates are going to come down very, very drastically, because we know the research cycle how it works. It takes a minimum of 5 to 7 years to develop a concept. But because of the AI, huge AI platform, we have seen in the last AI conference, the computing power of the chips now. The computing power of the chips in Taiwan and some new areas in China is so exhaustive that in one small computer screen, that much size chip is going to be enough to control the entire internet traffic of the day of the world. This is the computing power we are going to encounter now. With this computing power, the message is these things are going to be much cheaper, much wider. It is just like how the smartphone became widely available. So this is going to be very much killing to the giants in the IT technology.
One more as a
Thank
surgeon,
you.
I'll want one more question to Dr. Biju.
Sure, sir, please.
As technology evolves, it becomes useless to learn or even remember certain older things. We don't have to carry a calculator or even a watch now because it is redundant. But at the same time, not all of the old knowledge is useless. You still have to know addition, multiplication. We already are seeing a breed of surgeons who have been formed, who have not been exposed adequately to open surgery in the era of minimal access surgery. So that is a real problem. So when you cannot handle things by robotic or laparoscopy, the fallback option is an open surgery. In the next 2 decades, when AI becomes completely pervasive, do you think that we will have a major handicap of not being able to find surgeons who can operate without AI when the need arises, like an open surgery? Because the rate of conversion is definitely going to come down. We do not find much cholecystectomies being done in open because we don't convert. With AI, that conversion is still going to be rare. There'll hardly be a surgeon who will see an open surgery in his entire residency period. So if a need arises, open is what is the safeguard we are going to advocate to make sure that we also train surgeons for fallback options like an open procedure?
So my biggest fear is the different way. The people surgeons are acquiring less and less knowledge about the disease process. So that is the major problem. For example, what is the reality? How does the advanced liver cancer or stomach cancer looks like? What is the local infiltration means actually? This feeling is the biggest problem. Okay, so the understanding of the disease progression is going to be a bigger problem. Other problem is not that severe. I'll tell you why. For example, you ask a radiologist, excellent liver radiologist, he might not have ever seen a real liver. Okay, now a excellent endoscopist who might have never seen a real stomach at all. Okay, now we are going to enter to that territory also. For example, when we do laparoscopy surgery, we are actually not doing surgery on the patient. We are actually doing surgery on the images. Today also we are doing the same. So open surgery is required, but more importantly, when you do an open surgery or any laparoscopic surgery, what is inside that interpretation? Do you have the real feeling about the patient is going to be the problem? That is more going to be a problem. So the doctors who understand the disease process pathology complex scenarios are going to be high demand, whether they know laparoscopic surgery or open surgery. Yeah, thank you.
Angel ma'am.
One second.
We do have a few audience questions, which I think because of the time constraint, we will take in the panel discussion manner, if that's okay with our panelists.
Aishwarya, I have two questions to Dr. Biju.
Okay. Okay, ma'am. Go ahead, please.
Dr. Biju, I think you partly answered it, but how exactly AI is going to change the training?
Okay, so AI is going to have a very major impact on the training. Our conventional training models are going to be badly hit. The reason is you are taking class to a student, and why he should come to the class is going to be the biggest question when he gets up in the morning. That will be going to be a bigger question, because let us say we are trying to demonstrate a liver surgery. Imagine that he has an immersed reality platform in his room or laptop computer. He's not going to come here. So as you see how the conventional lecture system in classrooms change, disappearing in the big universities, IITs and other universities, they spend less time in conventional teaching. This is going to come here also very soon. So it is going to be a changer. Yes.
One more question, Dr. Biju. Can AI result in full automated surgeries?
Yes, it can result in full automated surgeries. But so let us say stent deployment, biopsy, all these are going to be the first thing which is going to, let us say you want a liver biopsy, a CT is there, you have a puncturing equipment loaded in a robotic platform, go press button, it will take the biopsy from segment 5. This is possible even now. But FDA give a what is a mandatory requirement is a human controlled switch stop at any stage, because ultimately it should be nearly 100% a proof that it is not going to harm any single human being. So that particular control is going to be there for some time, but even fully automated, some procedures are still possible. It is possible.
Thank you, Dr.
Thank
Biju.
you. Thank you so much. Thank you to our chairs as well for conducting this session. Next, we move on to the segment of a panel discussion. I have a few questions I would like to ask our panelists. May I start with Dr. Angeline, ma'am, if that's okay?
Yes, Aishwarya.
Yeah. Ma'am, I have a question to you. Can AI, do you think, reduce the vast difference in outcomes for similar emergency surgeries in countries with different developmental indices, like be it USA or India or Africa? Like, how do you think the difference in the care can be reduced using AI?
Yeah, Aishwarya, what happens, all said and done, there is a tenfold difference between hospitals worldwide, between a low-income country or a high-income country for emergency work, maybe for elective also. So the outcomes vary tenfold. That is quite a bit of a number. Whether AI can come and sort of standardize the whole thing is left for a lot of research to be done. Pilot studies are being done, especially in the public health space. And there was one study from Global Surgery Collaborative published in Lancet. And the question is whether AI and digital surgery can help reduce this gap or whether they might unintentionally widen it. This is exactly what Dr. Partha had raised with Dr. Biju. And Dr. Biju said that once technology gets going, sort of the costs come down. That is what happened, for example, your smartphones and your e-commerce. So probably we can hope that the same thing will happen with this technology also.
Exactly, because this is what also got me thinking that the question is, can AI reduce the variability in care? But do we really need to reduce the variability in care? Because everybody is so different, and that's where precision health is also headed, that it gives different health care to different people. So, do we need to reduce the variability in healthcare? And if yes, then how AI will help do that?
Aishwarya, there is a small confusion between variability and personalized care. It is not the same. Variability is actually what one surgeon would do to patient A and what another surgeon will do to patient A. So that is depends on a whole lot of things. It depends on the infrastructure that we have. It depends on the patient expertise, the available evidence that we have. Can AI come and sort of smoothen out all these jagged parts of a healthcare system and try to bring some sort of standardization inside? So that is what we talk about variability in care. Like somebody in the rural area may be getting a different type of care. I wouldn't say inferior, but a different type
Mm-hmm.
of care which may
Mm-hmm.
not be the standard of care. So
Mm-hmm.
whether AI can come and smoothen out these things. There are studies, especially in the public health space, to sort of put people in this direction and look at it this way when we are especially bringing AI into the healthcare.
Understood. Thank you so much. Thank you, ma'am, for clearing that up. I have a question to Dr. Partha. So, what do you think remains uniquely human uh, in the future of operating theaters?
Yeah, whenever we talk about AI in healthcare or surgery, it always has a rider fear that humans will become irrelevant to this and robots will take over. I think at least for a long time to come, there will be a definite unique human part of treatment of diseases. How much our AI takes over, there is clinical judgment which would take a very long time for AI, or probably that will never be given up to AI by humans. There is a lot of humanness to treatment beyond medicines and surgery that will continue to be our domain. And the nuances of treatment is not always dictated by the disease biology and the other objective factors. There are a lot of social factors, patient preferences, patient autonomy. Uh, uh, these things definitely will continue to be in the domain of humans. In the operation theater too, the human surgeon's role will continue to persist in a different way. He will no longer be the craftsman doing things. Rather, he would be a, a conductor of the orchestra, deciding who plays what and when they play their role. And the execution will get more and more perfect because it is being done by a very sophisticated, standardized AI guided machine. But for a very long time to come, I think humans will be the primary curers of diseases with the help of all of these.
Which is to also answer my next question, that the onus will always be with the surgeon, right?
Yeah.
Yeah. Okay. Thank you so much. We had one question, one audience question during Dr. Biju sir's presentation, and it's about the reliability of AI-driven recommendations. I think that's one thing that we have to talk about when we're talking about robotic surgeries. Like, how do surgeons respond if the system's approach is different than that of a surgeon's planned technique? I'm sure it's a collaborative the thing, but like, what is your take on the question that one of our curious members has asked?
This is for
Dr.
me.
Biju, Dr.
Yeah.
Biju, so if
One of the very frequent questions we encounter every time is whether can we depend on AI? Okay. So the answer to that is, see, I shown you one image where multiple skin layers are coming from the plain city. Okay. That image is created after reading 20,000 CTs. 20,000 CTs cuts are read to create the language algorithm. Now, can we create that in clinical scenario? Almost never. See, we create all the guidelines, everything just from 100 patients, 1,000 patients, or maximum 10,000 patients. This is the medical science, what we are talking. Here it is not that. Here, the numbers, the capturing methods of nothing. Even if you submit any AI project with a less than 10,000 N, it is not going to be approved at all. There's no point at all to doing that. So this comes from a very large N, the number. And if you see the Jacobi index and all these, the formulas which we use there, it is not p-values or Fisher's XR test or t-test which is used for a very small number of patients. These are very high-end sensitive specific. So it goes to a very, very rigorous, highest statistical modeling, then come out with modeling. So if you believe in medicine, if you believe in evidence-based medicine, you have no other option except to believe in AI, because it works on a higher sensitivity, higher data, higher platform. So that question probably we had to close that by this answer. That's what might be. Yeah.
Very well said. So, is there anything you would like to add, Dr. Partha, to it?
I agree with what Dr. Biju said, and the corollary to that is even during training, AI guided training will, when a student learns from a surgeon, he usually works with 2 or 3 teachers and learns from their experience over their 2 or 3 decades. And during the 3 years of his training, whatever he sees, so he gets a cumulative experience of 70 to 100 years during his 3 years. But with AI, with every surgery, every anatomy getting uploaded into it, if you want to learn a laparoscopic gallbladder surgery, the model which is going to teach you will contain lakhs of surgeries uploaded into its learning. So it creates like a huge collective surgical consciousness. And a student who learns from that master will learn from thousands of years of experience. So that is the training it imparts. So if you have a teacher standing in the operation theater telling you to cut and the AI telling you not to cut, whom would you follow?
Okay, that answers itself. Thank you so much. Dr. Biju, sir, we have to talk about the medical legal implications of AI when it comes to robotic surgery. What are your 2 cents on it?
So the problem is, as I said, it is going to be more accurate. There is no doubt. Everything is more accurate. So you should not disbelieve that. But now the part B, who is going to take the ownership? Currently, the constitution and the legal system say that if you want to use any tool, the person who is using that tool is responsible. For example, our energy system already have AI, Robotics has AI, but the law of the land say that you can't blame the robotic, you can blame the robotic companies, but if you are not convinced, do not use it. This is your individual right. So as a surgeon, medical council or your license give you an exclusive right, but that license comes with a rider. So ultimately, the law cannot catch a machine. The law can catch a citizen. So as a citizen, please be convinced with the machine. And if the machine malfunctions, you can blame the machine. But at the same time, if it routinely malfunctions and you are not noticed, the law of the land is not going to come to your rescue. That is why a lot of medical legal problems are coming. Let us say a cautery has burned much more. Okay. The AI platform detected a different tissue instead of a small important tissue. It burned more. Who is going to get blamed? The cautery machine or company is not going to get blamed. The surgeon who is going to get blamed. So please do remember that this catch is there. The law has not, the the control of AI comes from the government to the manufacturers at that point of time of licensing. But post licensing, please do remember that the tool is in your hand. You can reject that tool altogether.
Yeah, rightly said. I think with that, we come to the end of this wonderful discussion. Thank you so much, Dr. Angeline ma'am, Dr. Biju sir, and Dr. Partha sir. You kept the discussion very crisp and clear, and I really enjoyed and learned a lot on the topic of AI and robotics and minimally invasive surgery. Thank you so much, Dr. Angeline ma'am, to help curate this wonderful panel and give such a wonderful discussion to all our viewers. At Doctors AI, we keep continuing the discussions on medicine and how AI is changing it every minute, every second, if I may say. To keep the discussions going, we meet almost every Thursday. The second Thursdays are for MedAI Web Hour. The third Thursdays are for update hours, where we discuss all the updates that has happened over the last 30 days in the world of AI in medicine. And on the fourth Thursdays, we have journal clubs. Where we discuss a very intriguing, interesting article that has been published in any journal, peer-reviewed, indexed journal. Thank you so much for taking time out, everyone, and let's keep the discussions going. Thank you.
Thank you very much. Thank you.
Thank you.